Meanwhile, reports from the Ghana Medical Association is indicating that breast, liver, cervical cancers have become the leading forms of cancers across Ghana. To find ways to address the challenge, the Ghana Medical Association is currently holding stakeholder engagement as part of its 27th Annual Public Lecture for the way forward. We can cross over to Mervyn Pick, Ambassador Hotel now, for the keynote address of the lecture by Professor Benedict Calys-Tagoe.
In Ghana, to implement a national strategy for cancer control by working with some of you in this room, so that some of the things we discussed during the team today will happen and be enhanced. Since the signing of this MOU, the Minister of Health, through the NHI, has listed one of our medicine, Herceptin, and Maptera, to actually etc. matter, as part of the benefit package for breast cancer and childhood cancer, respectively. The impact has been deep, huge. I was speaking to one of our clinical oncologists earlier this week from Kumasi, and she told me the story of this young lady in the 30s working for a bank, show up at her clinics but could not afford this medicine. Her family was prepared to pay for one cycle, the bank was prepared to support for one cycle, but this happened at the time that the Minister of Health decided to make Herceptin free for most of the patients who need it in Ghana. 7 years down the line, she's still alive and she's seeing her kids growing. I think the purpose of the conversation today is to look at this type of example and see what might we do so that more this lady exists in Ghana and beyond. And that's one of the commitments that I keep giving to every stakeholder that I meet. We will do everything we can do so that we have more examples like this one. Not just to talk about, but also to ensure that we can learn from what's happened here. How did we manage to discuss with the medical community? How did we manage to discuss with the Minister of Health? How did we manage to discuss with the NHI to find this type of solution? To this point, this week alone, with the team in Ghana, our Roche team, I'm very proud of what you are doing. I met with Dr. Bernard Okoeboy of the National Health Insurance to discuss our joint partnership to make this type of thing happen. I'm delighted to tell you that NHI and Roche committed to strengthen our partnership by further collaborating so that more people can benefit of this type of situation. I'm totally conscious that we alone cannot do it. And we are also committed to share this story to more stakeholders so they can come and join us together so more patients like the one that the clinical oncologist from Kumasi share with me happen. Expanding access to our medicine in Ghana and beyond is central to what we do. We passionately believe that our innovation do not matter if patients cannot access it. Our innovation will not matter if patients cannot access it. Our innovation will not matter if patients cannot access it. And that's what we believe. We should sit today with you and find a way we can make it matter for the patients. We are committed to partnering with government organizations and other stakeholders to ensure that universal healthcare coverage goals are met and exceeded. Because the little that we are doing can reach most of the people only when universal health care goals will be reached, and we are conscious with that.
Desk, we can now go straight to the Movenpick Ambassador Hotel, where there's occurring stakeholder engagement as part of efforts to reduce breast, liver, cervical cancers, which the GHS, the Ghana Medical Association, says have become the leading forms of cancers across Ghana. And keynote address being delivered by Professor Benedict Calys-Tagoe. Let's listen to him.
The individual has no symptoms, nothing to show that they have any problem. The cancer is silently developing in the background, and the time is variable depending on the type of cancer and the person involved. This may go on for some time, sometimes weeks, sometimes months, up to years. And this is where screening programs come in very handy. In fact, there are some cancers that never produce any clinical manifestation, no sign whatsoever, and the person will die with the cancer rather than from the cancer. So that's the first stage. Then we have what we call the pre-diagnosis symptomatic phase. Here, there is onset of symptoms. People are beginning to experience all sorts of symptoms, and the symptom is dependent on what type of cancer they may have. The location of the tumor plays a very significant role. And this may either aid in early detection or, contrastingly, may delay the diagnosis due to lack of specific symptoms. Then we have the third stage, which is the diagnosis phase. Here, the diagnostic procedures may be straightforward or complicated. In some cases, you'd have to conduct several tests to identify the tumor and confirm its staging. Staging is an important crossroad because it determines the most appropriate type of treatment. And then obviously we would move to the next phase, which is the treatment phase. It is generally corresponds to the standardized stage of the cancer. So the stage of the cancer determines what sort of treatment you would receive. But it's an important crossroad because it is subject to potential complications or crisis that may be associated with the actual treatment or as part of the evolution of the disease. And then we have the maintenance phase, where the initial treatment is succeeded by a follow-up stage of varying stability. Here again, we may have crises which become evident through relapses, that is the appearance of the cancer or reappearance of the cancer following the treatment. Or maybe the result of the treatment, which may be treatment-related complications. The crossroad after maintenance stage has two different pathways. People would either receive a cure or they move on to palliative care. If you receive a cure, then you are safe. If not, then we move on. Long-term survival, that's the next stage. So those who overcome the maintenance phase and receive cure have long-term survival. Although the cancer for which they receive the treatment is considered technically cured, they enter into a new chronic stage of life. And so cancer survivors subsequently have to deal with the after effects of the treatment. The long-term complications of these effects, and sometimes the risk of developing another tumor. For those who do not receive cure and move into palliation, active cancer treatment is always combined with elements of palliative care that are applied more intensely in the advanced stages of the disease. The natural history of cancer is thus characterized by long periods of varying stability with some intercurrent crisis and end-of-life stages that last for a few weeks, months, or even years. Mr. Chair, before we proceed any further, we would want to address a very important question. Our theme talks about the epidemic of cancers. So the question is, do we really have an epidemic of cancers, or it's just a hype? This is a difficult question to answer, considering the fact that we do not have very reliable data in our part of the world. But we would make an attempt. So if we look at an epidemic, it is generally defined as having cases in excess of what you expect for that place at that time. Do we have excess of cancers? Let me make reference to the Globocan report for 2010, which are estimates for Ghana. And it tells us that these are adjusted for all other things, including age. As at 2010, for every 100,000 Ghanaians, we have about 109 of them suffering from one cancer or the other. Fast forward to 2020, same Globocan estimates. Now that figure is about 125 for every 100,000 Ghanaians. So if we work with a population of 31 million, then we are looking at 38,750 new cases. These are estimates for new cases, not the total burden. So what it means is that every year we are having close to 40,000 new cancer cases, as opposed to 27,000 10 years ago. Do we have an epidemic or not? You be the judge. But I think the figures speak for themselves. On the face of the pink sheet, it is very obvious that we have a looming crisis on our hands. Now, to put the Ghanaian cancer situation in its proper context, let's look at some key figures about cancers as provided by the World Health Organization. So cancers are the second leading cause of death worldwide, accounting for nearly 10 million deaths every year, and these are figures from Globocon 2020. When you come to low and middle income countries where Ghana belongs, we tend to shoulder most of the cancer burden. So if you look at the 10 million deaths every year, 70% of them are in low and middle income countries. Now this disparity is even more striking in the case of cervical cancer, where 90% of new cases and deaths from this preventable cancer occur in low and middle income countries. The cancer incidence in sub-Saharan Africa is projected to increase by more than 92% between 2020 and 2040. So almost 100% increase. And some projections have even said that by that time we are more likely to have more cases of cancer than that of TB, malaria, and HIV pulled together. And if you think that these are the major problems we have, and we'll be having more cases of cancer, that's something that we need to really work on. And that is why this theme is very apt. If we look at the extent of the problem globally, the common cancers are breast, lung, colon, rectum, and prostate cancer. These are global figures. And if you look at the 2020 reports, there were over 2.2 million new cases of breast cancer worldwide. Lung cancer, 2.21, colon and rectum, 1.9 million, prostate, 1.4, skin, 1.2, and stomach, 1 million new cases of cancers. When it comes to death from cancers, lung cancer tops the list globally, 1.8 million, followed by the colon and rectum, 916,000, liver 830, stomach 769, and then breast 685,000. You'd realize that at the global level, cervical cancer does not even feature in the list. But when we come closer home, it is one of our big problems. So let's get closer home and look at the cancer burden in Ghana. And here I'm looking at a 5-year prevalence. Breast cancer tops the list. For every 100,000 Ghanaians, about 66 of them would have breast cancer. So that brings it, if you work with 31 million, you are talking about over 20,000 breast cancer cases. Then it is followed by cervical cancer, which doesn't appear at the global level because it's a preventable disease. But we are still battling with it. And it's number 2. For every 100,000, we have about 39 people with cervical cancer. Then prostate cancer, followed by cancer of the ovary, and then that of the liver. So these are the overall 5-year prevalence. That's total burden. When we look at the new cases, again in the estimates we had 24,000 new cancer cases as per the 2020 report. And for our childhood cancers, on the average, we are having about 400 new cases annually. These are estimates, bear that in mind. And the common leading ones for the males: liver, prostate, non-Hodgkin's lymphoma, colorectal, and then stomach. For the females, it's the breast, cervix, ovary, liver, and non-Hodgkin's lymphoma. And for our children, it's the Wilms tumor, the retinoblastomas, the leukemias, and the lymphomas. These are the common problems we have. When we look at mortality from cancers, Globocon estimates that every year in Ghana, we have about 15,000 people dying from cancers. And just in case you are having a difficulty visualizing 15,000, I'm sure we've all seen aeroplanes. And we all know what happens when we hear of a road traffic accident involving, let's say, a U-turn bus, and you are told everybody on board died. What's your reaction? Oh. Now, if you want to visualize 15,000, it's like having 25 Airbus 380 aircrafts. You know, the huge ones. Each of them carries on average 600 passengers. And it's like having 25 of them crashing with all passengers on board dying every year. So on average, we have 2 crashes every month. Just visualize that. How many deaths do we get from COVID? As at the end of March, it was about 1,400, less than 1,005. But I'm sure you all know the frantic measures we put in to deal with COVID. Why are we not making such noise about cancers? The answer is very simple. We are not angry enough. And why are we not angry enough? Because we don't have the information. Awareness creation is one of the big challenges that we have. So my aim this morning is to make you very angry by the time you leave here. Angry enough to make noise about cancers. Angry enough to be willing to go to development partners and make noise. Angry enough to prioritize it and move it from the back burner to the front bench for discussion. What are some of the risk factors? What are the causes of cancers? Cancers will generally arise from transformation of normal cells. You know, generally the body would replace cells that are wearing off and dying. Now, when this multiplication or replication goes wrong, then we can have cancer. So in that multi-stage process, changes can happen, things can go wrong, and we can have what we call precancerous lesions. And these will progress to become malignant tumors. These changes are usually the result of the interaction between a person's genetic factors and at least 3 categories of external agents. Now, these external agents are the physical cancer-causing agents, what we call carcinogens, such as ultraviolet and ionizing radiation. Then we can talk about the chemical carcinogens, components of tobacco smoke, alcohol, aflatoxins, which is a food contaminant, and arsenic, which is a water contaminant, and also asbestos. And then we can have the biological carcinogens, such as infections from certain viruses, bacteria, or other parasites. When we look at the exposure to radiation, it's much closer to us than before. I mean, just looking around the room, I believe everybody has a cell phone or two. Some are closely packed in our pockets. Others are in our breast pockets. In addition to our mobile phones, we have tablets. We have laptops, iPods, iPads, all sort of gadgets. All right. There are some schools of thought that have suggested associations between radiations from these gadgets and cancer causation. However, current available evidence does not support this. That doesn't leave us off the hook. The reason being that much research is needed in these areas. These mobile devices have not been with us for that long, and we cannot tell the long-term effect of these things, so we need to tread cautiously. So we can start by keeping our phones away from our bodies as much as possible. And please, don't put it under your pillow when you are sleeping. Some of us, if somebody sees the contents of our phone, when our phone rings, it's like we are possessed. Please keep it away. And then tobacco. Tobacco use, this cannot be overemphasized. It's long been identified as a major risk factor for cancer development. And tobacco smoke is made up of thousands of chemicals, of which at least 70 are known to cause cancers. And in this regard, the youth of today think that shisha is a way out. So let me burst your bubble. Shisha is very trending among the youth now, especially the females. And it is no less harmful than cigarette smoking. In fact, in a shisha session, which usually lasts for 20 to 80 minutes, a shisha smoker can inhale the same amount of smoke as a cigarette smoker consuming 100 sticks of cigarettes. Yes, you heard me right, 100 sticks. So in case you were thinking shisha is a safe option, passing it through water doesn't make it any less harmful. Also, the amount of aldehyde compounds, some of these carcinogens, carbon monoxide and tar, that is found in one shisha smoking session is 4 to 30 times more than in a single session of cigarette smoking. And these are potential carcinogens, making reference to the aldehyde, the carbon monoxide, and the tar. And they combine with other toxic substances. Let's talk about alcohol. Hello? Hi. Mr. Chair, anytime we talk about alcohol, there is controversy. Because people like the green bottle. People like it. And it's even evident by the adverts we see around. I mean, just tune on your radio or your TV and you hear from one bitters to the other. At the last count, I counted about 71, and I lost count. New ones keep coming up. I hear that the latest one is Walat and Wallace. I don't know which one is coming next. But alcohol consumption is another major risk factor for cancer development. And this is evident from the high patronage that the numerous alcoholic beverages and bitters receive. The fact, however, remains that alcohol is classified as a group 1 carcinogen. It's in the same category as tobacco. And group 1 simply means that there is enough evidence to conclude that it causes cancer. So whether we feel comfortable or not, alcohol is a risk factor. And it does this largely through its toxic product, the acetaldehyde, which damages cells and causes them to replicate incorrectly. It also influences the level of certain hormones, which can modify how cells grow and divide. Alcohol also exerts its effect on the liver, and it's a major contributor to liver cancers. If you looked at what we mentioned for Ghana, liver cancers was one of the top ones. Then we talk about water pollutants. And of concern in recent times are arsenic and mercury. These chemicals have become major pollutants of our water bodies as a result of the proliferation of galamsey activities in our country. And let me mention that galamsey poses an existential threat. It's a threat to our very existence. All of us are at risk, and it results in heavy metal pollution of our water bodies. Mercury is a product used in the extraction process, whilst arsenic is a byproduct. And methyl mercury, which is a compound of mercury, has been classified as possibly carcinogenic by the International Agency for Research on Cancers, while arsenic and its compound, as well as its presence in water, have been classified as carcinogenic by the same institution. And this is another reason why we must all take a stand against galamsey. It's not just about those out there. If we don't take that stand, very soon we'll start importing water, because all our water bodies will be polluted with arsenic, and we are not sure what will happen to us and our future generations. So let's take a stand. If you think you are in Accra, so you are not affected, you know, these chemicals are carried on in the food chain. So I was talking to Matt earlier, and he was telling me he enjoys his tilapia soup. Very soon that tilapia will be contaminated with mercury. So you are sitting at Mervyn Peak eating your grilled tilapia, but you are eating mercury from Takwa. And so we all need to be involved. The incidence of cancers also rise dramatically with age, most likely due to a buildup of risk factors and specific cancers that increase with age. The overall risk accumulation is combined with a tendency for cellular repair mechanism to be less effective as we grow. Then we have the cancer-causing infections, such as the human papilloma virus, and then hepatitis B and C, Helicobacter pylori, the Epstein-Barr viruses, and these are together responsible for approximately 30% of cancer cases in our part of the world. Hepatitis B and C obviously are a risk for liver cancer, while the HPV, human papilloma virus, is a risk for cervical cancer. Infection with HIV increases your risk of developing cervical cancer by 6-fold, and it substantially increases the risk of developing other cancers such as Kaposi sarcoma. Our current lifestyles add to the trouble. We have increasing levels of physical inactivity. Technology is not helping us. So now you can sit at one point and with a remote, turn on the lights in your house, turn off the TV, turn on the AC. Very soon AI will help us to dish food, and we won't have to even go to the kitchen. So now we have to make a conscious effort to incorporate physical activity into our daily living. High body mass index. You know, in our part of the world, it's nice to look nice, especially when you have rounded curvatures. They say you need to have something to hold. So it's a sign that your husband or wife is taking good care of you. As soon as you become tingelingi, people start asking, is he not taking good care of you? But high body mass index is a risk factor, and so is our low intake of fruits and vegetables. And when it comes to cancer deaths, 1/3 of deaths from cancers are due to tobacco use, high body mass index, alcohol consumption, low fruit and vegetable intake, and lack of physical exercise. So we see, how do we reduce the cancer burden? Generally speaking, about 1/3 of all cancers are preventable. Another 1/3 can be cured. And the last 1/3 are amenable to palliation. So cancer follows the rule of thirds. So if we look at that, if we are able to avoid the risk factors or reduce these risk factors, and we add early detection to it and prompt treatment, close to 70% of all cancers that we encounter can either be prevented or cured. And this is the window of hope. So how do we prevent it? There are various measures. At the primary level, I realize that the biggest challenge is lack of awareness. Lack of awareness. So if we want to prevent cancers, we need to start by making noise. Get angry enough to make noise. You know, I remember the 2014 when we had Ebola in our neighboring countries. We made so much noise that even the traders on the road, they were educating people. Some were calling it Deborah and Ebola and whatever. But at least they knew there was something. Let's make noise to the point where the ordinary person on the street can tell you about cancers. Let's create awareness. How can we do that? We can have dedicated months. For some of the cancers, we already have dedicated months. January, they say it's cervical cancer. But how many of you knew that March was dedicated to rectal cancer? No, we don't. How many of us know that April is dedicated to pharyngeal cancer? These are international months that are dedicated to these cancers. Can we make a lot more noise about them? May is for skin cancer. September is for prostate cancer. October is for breast cancer. November is for lung cancer. And we can go on and on and on. Let's make noise. Let's create awareness. Then there are the cancer ribbons. Different colors signifying the different type of cancers. I'm sure you all know about Pink October. But how many of you know about light blue? What does it signify? Prostate. So you see, when you see somebody with a light blue ribbon, and then the teal or white is for cervical cancer, orange is for leukemia, and so on and so forth. Let's make noise. Let's create awareness about this. And in this regard, I'm expecting that the Health Promotion Division of Ghana Health Service would collaborate more effectively. I know they are collaborating, but they should collaborate more effectively with a non-communicable control program to create the needed awareness as a first step to cancer prevention. We can go on and even use brand ambassadors for the various cancers. I'm sure you've heard about the Shatter movement. Imagine what will happen if we make Shatawale a brand ambassador for prostate cancer. I mean, the fact that you belong to the Shatter movement alone. We have the which other one? Beam Nation, right? And then there's Success. I'm sure you know them. Imagine what we can do if we incorporate these brand ambassadors. You know, the music industry is a viable one, and we can leverage on their celebrity status to create awareness for cancers. Another preventive measure is that of vaccination for those for which there are vaccines. HPV, the human papilloma virus. There are vaccines, and that can help reduce cervical cancer, which is one of the topmost on the list, vaginal cancers, vulvar cancers, and anal cancers. You know, these days, issue of sexuality is some way. That's a discussion for another day. Then there is also a vaccine against hepatitis B. Let's take advantage of these vaccines. Another primary reduction measure is that of reducing our risk, the risk factors. So, can we avoid tobacco smoke? You may not be the primary smoker, but secondary smoking is as harmful as primary, if not worse, because you are taking in all the harmful carcinogens in addition to what the primary smoker is bringing out. Can we avoid tobacco? Can we work towards maintaining a healthy body weight? It's good to have it rounded, but let it be in proportion to your health. Can we establish healthy eating habits? Incorporating more fruits and vegetables. Fortunately for us, we have a lot of these things that are in seasons. They come in seasons. So if it's watermelon season, please enjoy the melon. If it's orange, you don't need to go and look for apple. We are brought up to know that an apple a day keeps the doctor away. An orange a day can do the same. So can mango a day. All right, so let's patronize what is in season. Usually when they are in season, they are less expensive. Our mothers here can tell you, they are the ones on the market. So can we have a conscious plan to engage in physical activity where we are looking at a work-based or a school-based approach, such that employees or employers can have a place where employees can exercise either before or after work, rather than spending 3 hours in traffic. If you use 1 hour of that time to exercise, by the time you get home, you'll still be tired anyway, but then tired with benefits. Can we avoid or reduce our alcohol consumption? These are some of the risk factor reductions that we can adopt. Then it comes to the secondary prevention measures. We are looking at screening and early detection. And screening aims to identify individuals with findings that are suggestive of a specific cancer or pre-cancer lesion before they develop symptoms. When these abnormalities are identified, further tests to establish a definitive diagnosis should follow, and this should be linked to a referral center if it is proven to be cancer. The patient selection for screening program is usually based on age and risk factors. See, it's good to screen everybody, but at the same time, you have to balance it with the capacity of the health system. Otherwise, you would overwhelm the system and it will come crashing down. So we need to find a fine balance. So we have screening programs for HPV, and now we are recommending more of the HPV DNA. If you are negative, there are vaccines available. We have mammography for screening breast cancer for women who are aged 40 and above, or those with strong family history. And there are others when it comes for screening. But quality assurance is required both for screening and early diagnosis programs. When identified early, cancer is more likely to respond to treatment and can result in a greater probability of survival with less morbidity, as well as less expensive treatment, which is very important. Significant improvements can be made in the lives of cancer patients by detecting cancer early and avoiding delays in care. When we look at the early diagnosis component, we can identify 3 components of this. Number 1 is being aware of the symptoms. So people need to be made aware of the symptoms of the different forms of cancers and of the importance of seeking medical advice. Unfortunately, majority of our patients present late. It doesn't matter which type of cancer we look at. Majority of our patients present late. And because they are presenting late, the outcome is usually not very good. And that serves as a deterrent for other people who are diagnosed with cancer, because they then see it as a death sentence. I mean, interacting with women in Jamestown, they will tell you, once you go to the hospital with cancer, they are going to cut off your breast. And as soon as they do that, you will die. And that is because people come at very late stages. But if we can pick it up early, if we can create the needed awareness, then we can change that narrative. So we need to work on creating awareness. Then the second component is access to clinical evaluation and diagnostic services. Using our primary healthcare approach, we have to build the capacity of all cadre of healthcare workers, especially those at the periphery. You know, the specialized care would be at the tertiary and referral centers. But most people would go to the CHIPS centers. They would go to the polyclinics. They would go to the health centers. That's their first point of call. And we need to build capacity at these places so that they can detect and then link these people to care. It is not rocket science to be able to use acetic acid, visual inspection with acetic acid, to pick up precancerous cells of cervical cancer. And at the same time, it is easy to use either self-breast examination or clinical examination to pick up lumps that may be pointers to breast cancer. And here I would like to pay glowing tribute to one of our colleagues, Dr. Kofi Efa, and his team at Bato. They are doing a yeoman's job. They are using what we call the hub and spoke approach. So they have a center in Bato, and they have trained people at the periphery. And they are trying to expand, but they cannot do it alone. And so I would want to entreat all stakeholders to think of how we can replicate this in other parts of the country. Then the third component is the timely referral to treatment services. People are screened, they are identified as having cancers, and between the time of diagnosis till they get to a referral center for definitive treatment, many of them get lost in transit for various reasons. Sometimes it takes several months, and in some extreme cases, years after an initial positive screening or diagnostic result for these patients to be linked to care at an appropriate referral center. The reasons are multifaceted. Lack of communication between the various levels of healthcare. Another big monster is the funding for cancer care. Cancer treatment is expensive, and we'll talk about that in a moment. Then we also have the skewed distribution of our health facilities and our health workforce, especially those that are involved in comprehensive cancer care. And there is the ignorance and fear on the part of our patients. Cancer programs should be designed such that they would reduce the delays in and the barriers to diagnosis, treatment, and supportive care. When it comes to prompt treatment, a correct diagnosis of cancers is essential for appropriate and effective treatment because every cancer type requires a specific treatment regimen. These treatments would usually include surgery, radiotherapy, and or what we call the systemic therapy, like chemotherapy, hormonal treatments, or targeted biological therapies. The proper selection of a treatment regimen takes into consideration both the cancer and the individual being treated. Completion of the treatment protocol in a defined period of time is important to achieve the predicted therapeutic results. Now, determining the goals of treatment is an important first step. The primary goal is generally to cure the cancer or to considerably prolong life. Improving the patient's quality of life is an important goal, and this can be achieved by support for the patient's physical, psychosocial, and spiritual well-being and palliative care in terminal stages of cancer. Some of the most common cancer types, such as the breast cancer, cervical cancer, oral cancer, and colorectal cancer, have high cure probabilities when detected early. Again, the catch here is early detection. So when detected early and treated according to best practices, the cure rate is high. Some cancer types, such as testicular seminomas and different types of leukemia and lymphomas, have high cure rates if the appropriate treatment is provided, even when the cancerous cells are present in other body parts. Let me talk about a very important area: financing of cancer care. When it comes to financing cancer care, this is a major challenge. Currently, we have some options available. The National Health Insurance. In recent times, childhood cancers have been brought on board, and this takes care of about 60% of the common childhood cancers we have. This is good in theory, but we have a challenge on the ground. You know, most of the cancer drugs are very expensive, and if we would be fair to ourselves, we are not paying realistic premiums. and therefore the health insurance is not paying realistic tariffs. The monies that they reimburse these pharmaceutical companies with sometimes are much lower than the actual cost of the drugs. And therefore, there are many pharmacies that refuse to sell these prescriptions when they are presented on the ticket of national health insurance. So even though on paper, national health insurance is taking care of these cancers, in practice, on the ground, these patients are not benefiting because the pharmacies will not dispense it because they risk running at a loss. Let's look at it. What can we do about our national health insurance? You cannot continue adding on without increasing the sources of income. Can we think of having a tier system where rather than the basic premium, some premiums are as low as 24 cedis. I don't know what 24 cedis can do a year. But those are the premiums you and I are paying. Some pay 72 cedis, and we expect to get quality cancer care. Can we think of having a tier system where beyond this basic, just like we have for private insurance, those who are willing to get additional services should be willing to pay an additional premium so that we have enough revenue coming in? It's something that we can think about. The out-of-pocket payment still exists, and where the individual does not have that muscle, then we resort to social support groups. And I'm sure you've seen a lot of those social support groups. Help needed. And then it goes on social media, people raise funds. I'm aware that the cancer fund has been proposed by the non-communicable disease, but this is yet to be approved. Please, those who have the power to make it happen, let it happen. Because without this, all the noise we are making will not go anywhere. When people are diagnosed and they don't have the capacity, it will be back to square one. The final thing I would want to talk about before I take my seat is that on cancer registration. Cancer registries are an essential part of any rational program to control cancers. And I'm sure you may be aware that there have been several attempts at having cancer registries in this country. Some started before I was born. But it was not until recently, 2010 thereabout, that we started having functional cancer registries. I am told that there are 5 cancer registries in the country. That in Kumasi, Korle-Bu, Cape Coast Teaching Hospital, Ho Teaching Hospital, and Tamale. I am not sure the levels at which these registries are. But on record, it's only the Korle-Bu and Komfanoche ones that are population-based. In other words, they are not collecting data only from the hospital, but they are looking at what happens in our communities. And when it comes to estimates for Ghana, unfortunately, it is only the Kumasi registry that is currently recognized by the Association for Cancer Registries. So all the estimates we are having for Ghana are based on data from the Kumasi registry. So you can appreciate why it's underestimated, because they cannot be everywhere at every time. And so cancer registry takes money. We need to put our money where our priorities are. If we are not getting the data, we will not be able to manage the cancers well. We will not be able to make the right projections, and we'll deal with estimates. With all the expertise we have in Ghana, I don't see why Globocon should still be modeling cancer statistics for us. We should be able to generate our own data. And if we're able to have these registries functioning at all our regional hospitals using the same software, then it only becomes a matter of collating their information at a central location. And then we have a national cancer registry. It is possible. Countries like Zimbabwe have done it. And we say we are richer than them. Countries like Uganda have done it right here in Africa. So it is not beyond us. Let us just get angry enough. And let's put our money where our priorities are. So, Mr. Chair, distinguished ladies and gentlemen, in conclusion, cancers are assuming an alarming proportion of morbidity and mortality, especially in our part of the world. We cannot continue to sit and wait for solutions from donors as usual. To a large extent, we have the men and women with the requisite skills and expertise to control cancers. What is lacking is adequate funding and political will. Adequate funding, and I'm re-echoing this so that all the partners and stakeholders would go home with that. Government should take the lead by prioritizing cancer control in its budget. I would be glad to see a line for cancer management or cancer control when that budget for Ministry of Health is approved. As a nation, we always find money to organize by-elections whenever the need arises, whether it was in the budget or not, because we do not want to derail the democratic process. Let us attach the same importance to health care in this country, and particularly to cancer control. Thank you very much. Wow. I think a standing ovation is appropriate.
And that was Professor Calys-Tagoe educating us on how to prevent cancers of the liver, breast cancer, cervical cancer, and the other cancers. And it's part of the 27th annual conference of the GMA. That will be it for the extended version of News Desk this morning. My name is Aisha Ibrahim. Less than 30 minutes, midday News Today. We'll be meeting again. See you again.